Are we on camera?
Oh, we can,
You can see us.
yeah.
There's
There he
Frank.
is.
Yeah.
Okay.
Wow. That was easy.
That's some good 8 a.m. problem solving.
By taking
Nice
notes
work,
on what we
team.
did.
Yeah, just do it again next time.
You are live.
We're live. Excellent. Good morning, everyone. I'd like to call this meeting of the Cook County Public Health Human Services Board to order on this Tuesday, January 20th at 8:44 a.m. Worked through some technical issues, and now we're ready to roll. First item is the call to order, and the next is election of the 2026 PHHS Board officers. First one is the election of chair. Are there any commissioners who would like to be chair? Or would anyone like to nominate someone who would like to be chair? Commissioner Sullivan, Commissioner Gamble?
I would like to nominate Commissioner Mills to continue in the role, just as at our County Board of Commissioners. I think a little continuity would go a long way at this time.
Support, you passed the technology portion of the. Yes.
Okay,
Pop quiz.
that was your nomination?
Yeah, I'm
Okay.
supporting the nomination.
Okay.
yeah.
Are there any other nominations? Are there any other nominations? Are there any other nominations? Hearing no other nominations, I'll close the nominations and we'll have a vote for Commissioner Mills to be chair of the PHHS Board for 2026. All those in favor?
Aye.
Those opposed, same sign. Motion passes unanimously. Thank you all for your trust and support. And now on to the election of vice chair. Is there any commissioner who would like to be vice chair, or are there any nominations for a commissioner to be vice chair? Not everyone at once.
I'll make a motion to have Gary Gamble be the vice chair if he is interested.
That's fine.
Good.
Pick somebody.
Yeah. Any other nominations? Any other nominations? Any other nominations? Hearing or seeing none, I'll close the nominations for vice chair. I'll call the vote for the vice chair as Commissioner Gary Gamble for 2026 Public Health Human Services Board. All those in favor?
Aye.
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 Opposed? Motion passes unanimously. Thank you. Moving on to item 3 is the approval of the consent agenda. Our consent agenda has our meeting agenda, the minutes from December, financial report, year-end donations report, abstracts and bills, renewal of purchase of service agreement with North Shore Health for home health care services, another renewal of contract addendums with Sawtooth Mountain Clinic, another renewal of purchase of service agreement with Arrowhead Health Alliance for adult mental health services, and then another renewal of purchase of service agreement with Arrowhead Health Alliance for mobile crisis response services. Are there any items a commissioner would like to pull to discuss, or any adjustments to our agenda? Commissioner Gamble.
Yes, thank you. I would like to pull C, which is the financial report, please.
All right. Anything else? All right. Commissioner
Yes,
Gamble. Oh, yeah.
Commissioner?
Oh, yes. Thank you, Frank. Yes.
Mr. Chair,
Yep.
thank you. I would just, I had a couple questions about the Mobile Crisis Response Center.
That's item I.
I don't have that in front of me.
Oh, okay. Yeah, it is. Okay, it's item I. That's fine. Thank you, Frank. Any other items? Commissioner Gamble.
Yeah, thank you, Mr. Chair. I would make a motion to approve the consent agenda with the adjusted noted items C and I.
Thank you, Commissioner Gamble. We have a motion as their support.
Support.
Thank you, Commissioner Sullivan. Motion is, yep. Thank you, Frank. We have a motion and support. All those in favor? Aye. Opposed?
Aye.
Same sign. Thank you. Frank, just to be clear, I'll talk slower and move slower. That was an aye in favor?
Correct.
Yes, okay, thank you. There's just a little bit of a delay, so I'll take that into consideration. But that was unanimous approval. Thank you. Let's talk about the financial report.
Thank you, Mr. Chair. I just wanted to point out, or not point out, but ask the question relative to the financial report. This is a financial report year-to-date through December 31st, 2025, and it reflects the expenditures as well as the collections. And I'm just wondering, on the collections side of things, when we look at those that are below 50% of collections, how much of that, if we were to doing a year-to-year comparison, is typical, and how much of that is a reflection of what we've been going through in public health, human services, or other issues? So just looking for an explanation as to those items. We have some items that are significant below on the collection side of things.
Then I'm going to pass that over to our new director, who will pass it on to our fiscal supervisor.
That is
bet,
correct.
but
I will
yeah.
pass that on to Plowman for explanation.
Good morning, Plowman.
Good morning, everyone.
Morning.
Just for the record, my name is Plamen Dimitrov, and I'm the fiscal supervisor for Cook County Public Health and Human Services. The answer is not as straightforward as, because it's different for every line item. But I'll start in general, and I'll elaborate a little more. When we say that the report is as of December 31st, that's true, but we have a lot of expenditures which we report to the Community Health Board for grants that we have incurred, but we have not received the reimbursement for. Same with the state of Minnesota. We're just now completing our state reporting to the state of Minnesota, and based on those reports, we'll be receiving reimbursement. So what we're gonna see in the next, and as a reminder, we can continue to pay expenditures for the previous year through February of the following year and receive revenue through March. So what I've done, and I've in the previous years, and I continue to do this year too, is I have a projections file that I run based on revenues and expenditures from previous year for those months that have not occurred yet. So when I'm looking at that projection at the end of March 2026 for 2023, we are going to be looking at return to fund balance for economic assistance by a minimal amount of $7,000. Social services will, use a fund balance for economic assistance of $7,000, basically breaking even. Return to fund balance by the social services department. Slight use of fund balance in both public health department and the child care program. All in all, we budgeted to use $566,645 of fund balance. My projections right now are that we're gonna only use $163,000 of that. So we'll be about $400,000 better than we budgeted. We all know why those are. I mean, we had a lot of staff turnover, which we saved some payroll, but we also have continued to seek grants to reimburse us for expenditures for our staff time too. Those are a mobile crisis response grant, who covers a lot of salary for our team, and we have the Community Health Board grants that cover significant amount of our public health team too. Now, when we go line by line item, and I mean, we could do that at some point, probably not during this meeting, but you'll notice that a lot of the expenditures where we have lower percentage. I'm sorry, a lot of the revenues that we have lower percentages because the expenditures are low too. One example is the developmental disabilities under the social services team. We've only expended 27%. Well, we only have 23% of revenue too. So there is relation, many of those, there is direct relation between the revenues and the expenditures. If the expenditures are lower, the revenues are gonna be lower too. And again, it's too early to be looking at this as a final. This isn't the final for 2023, for 2025. We have a lot of revenue to receive yet through the month of March. So in the coming week, board meetings, I will present to the board the financials for the current year and continue to update the ones for 2025. So you can be looking at the progress we're making on some of those line items.
Thank you, Mr. Chair. Thank you, Plemon. So the reason for addressing this, just from a fiscal standpoint, is understanding the finances we have as a county. Oftentimes, we get revenues that come to us later in the year, so it doesn't all happen simultaneous, so that the numbers reflect the actuals until we finally get those payments. So that's understood. I think overall, understanding from your position in the financial department is that whether or not what we see is we would consider to be good, healthy, responsible stewardship of funds. If we have revenues that come as a result of grants that we're applying for that reduce the portion of expenditure coming from public health human services that is levy dependent throughout the year, then when we come to financials and we do a review of them, understanding what we have done to reduce that burden is beneficial. The other is the consistency in the filing of documentation to receive the funds that are available to us when we comply with that. And so again, back to the overview from your perspective, when you look at it, understanding that monies come in later, so this does not reflect the actual, that to the extent that you say, I'm comfortable with what I see here, given our normal practices and the revenues and when they come in. And so if a layman looks at this and says, why are these discrepancies there? It's just understanding them from the standpoint of you saying, I'm comfortable with everything here, and there's nothing that necessarily needs to be changed. To the extent that we have generated additional revenue through grants and things that reduces the financial burden to the taxpayer, that's a good thing to note too. So those are the things I think, both for commissioners, but for the public as well, to understand these numbers in that context is important. And so your response could be that given what we've gone through in public health human services, we were not able to file some things, and so we lost some dollars here and there, which is something we need to correct. And if that's not a big concern, then that's a good thing to know. Because in some years, our filing on a timely basis for reimbursement hasn't been done, and we've had to address that. But that overall evaluation is just what I'm looking for, so the public understands that we understand that everything looks healthy.
I mean, currently we're at 101% of our expenditures and 92% of our revenues, so I feel comfortable where we're at. And again, based on my projections, we will be probably $400,000 use of fund balance less than what we budgeted. So I have, at this time, I have no concerns.
Yeah, thank you. I appreciate the explanation.
Thank you, Commissioner Gamble. Any other questions? All right, we'll move on. Sorry to keep staff here, but item I, I'd just like to knock out here too with the mobile crisis contract. Frank, did you have specific questions there?
Yes, I did. It's actually two related questions. The first question is, considering the recent incident at the co-op, the knifing incident, and evidently there were people who were aware of the potential for danger to self or others earlier in the day, would this have been if someone had made a call to the mobile crisis mental crisis hotline, would this have been a case where the mobile response would have been deployed? And if so, what would that response look like? Like, does somebody drive up? Does someone, what happens?
Okay.
I can give an overview for mobile crisis. So when a person calls the mobile crisis number, they could call 988. They could call first call for help. They could call our front desk and be routed to mobile crisis through the front desk team. The way that the service is set up, there's an initial conversation that's a screening conversation. And if they screen in for mobile crisis response services, there's a consultation with the clinical supervisor who, for us at this point, is based out of Brightwater. And that conversation is the conversation that assesses whether mobile crisis is an appropriate response. There are situations where they may not screen in, and they may have additional conversations over the phone. There's also conversations where if there is a danger to, the responder or to the individual calling, requesting the service, that there may be co-response with law enforcement. So I can't speak to exactly what this would have looked like in this specific incident, but I can walk through what the steps are for utilizing mobile crisis. I'll also note that the way we have the service set up and staffed right now, it runs basically business hours, so Monday through Friday, 8 to 4, and then in the evening and weekend hours, it's Brightwater. So it's done through telehealth because staffing the service 24/7 is not feasible for us at this point in time. So what it would look like if a call were to come in after hours is that the person who answers the call and has that, screening relationship would all be based within Brightwater, and then it would be available via telehealth to the individual calling and requesting the service.
Okay, thank you.
All right. And you, Commissioner Gamble?
Yeah, thank you, Mr. Chair. Does mobile crisis have a protocol that's clear to those that participate, and are there scenarios that are run so that they understand what their response would be? I mean, a lot of time when you're talking about crisis experiences, it's anticipating and addressing things up front so that we have a procedure that we follow so that the emotion of crisis.
Yeah, we definitely have a strong training plan for anyone providing the mobile crisis response service. So anyone who is providing the service needs to be qualified as a mental health practitioner per state statute and go through all of the required trainings to be able to provide the service locally. When we do, our call volume remains low. We average around and sometimes less than 1 call a month, which is challenging for training purposes. We're working right now with Brightwater to see if our current response staff can do in-person shadowing in Duluth with the Brightwater team, just given that despite our best efforts to create a robust training plan, the call volume remains a challenge because there is real value in doing in-person response work as a component of the training. And it's included, but it's fully dependent on the calls coming in for us. So that's something that we're actively working on right now as well.
Thank you.
Thank you. Good questions, good conversation. Anything further from you, Frank?
No further questions on that. Thank you.
Okay,
Thank you, Greg.
Yeah. All right. Commissioner Gamble and Commissioner Sullivan. Holy cow. Okay, go ahead.
Go ahead.
Well, I said Commissioner Gamble first, sorry.
All right, okay. Well, thank you, Mr. Chair. I was just going to make a motion to approve items C and I on the consent agenda.
Thank you.
And I was going to do the same thing, so support.
Excellent. We have a motion and support. Any further discussion there? Hearing or seeing none, all those in favor?
Aye.
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 Those opposed? Motion passes unanimously. Thank you very much. Now we're down to item 4, welcoming of new staff.
All right. Well, I'm very, very excited to welcome, we have 3 staff on, and then we actually have, Olivia popped out. We have 3 staff who are here who have joined our team since the last PHHS board meeting. We have Daniel McFarlane, who is joining us as a family services case manager. We have Amaris Fisher, who is also joining us as a family services case manager. And then we have Sarah Dragswick, who is joining us as a behavioral health services and clinical supervisor. So we're thrilled to have all three new members of our team here training in onboarding and, starting to work every day towards fulfilling our mission in the community. So welcome to all three of you. And I don't know if there's anything you'd like to add or comment on.
I'm just
Mr.
very
Coach?
grateful for you all joining the team. Much needed help, and really appreciate your willingness to step up. I don't know if there's anything you want to say about yourselves, background, and whatever. Nothing. You don't have to, but you're welcome to.
Well, thanks for opening up the doors and letting us in. Appreciate it.
I want you to feel welcome.
I've been in family services for a long time, so it's good to be back in that seat again. I was doing adult mental health for some time, but I like working with families most of all. And so I'm just happy to be back in that seat, so thank you.
Yeah, thank you. Yeah. Any questions for anyone?
Anybody coming from southern states changing their mind?
Okay, well, we won't keep you any longer, but it's wonderful to meet you and to see your faces, and yeah, have a wonderful day, stay warm, and we'll see you around the building, eh?
Good.
All right, thank you.
Thank you all.
And that moves us down to item 5, our Community Health Board presentation.
So I can introduce our guests here as they set up. So part of our presentation and the reason for inviting our guests here today is to give orientation to the governmental public health system and the roles that both the state, the region, through our community health board membership, and here at the county, our local jurisdiction play in the governmental public health system. In the coming months, we will have a presentation from our contractor, Megan Mose, regarding our department. And given the history over the past year, as well as her area of expertise, it'll be largely focused on the human services side of our everyday service provision. So inviting our guests here today is opportunity to provide some additional context into our structure and responsibilities as part of the public health system. So I'm pleased to introduce, we have Dee Finley, who is on the phone with us, joining from the Metro, who works for the Center for Public Health Practice, along with her colleague, who is here in person, Janelle Lambert. We also have Susan Michaels, who's the director of the Carlton Cook Lake St. Louis Community Health Board, which I'm not going to get ahead and over-introduce the different roles of the organizations, but this is a joint powers board of which we are a member, and Commissioner Mills also serves as, and Frank as well. They both serve as our voting members on the Community Health Board. So looking forward to hearing from our partners and answering any questions the board might have of what our role in governmental public health looks like.
Thanks, Grace. It's always a pleasure to be here in Cook County. I really appreciate working with Grace, and it's been really exciting to see her grow over the years. I was here when she was hired, and so we've been really fortunate to see all the great work that she's done in public health here, and so I look forward to working with her as the Public Health and Human Services Director as well. As she said, I'm Janelle Lambert. I'm a public health system and nurse consultant with the Minnesota Department of Health, so I support local public health infrastructure. There are 6 of us across the state. 5 of us work in the different regions, and 1 is a tribal system consultant. My region is Carlton Cook, Lake St. Louis, your CHB, Aiken, Itasca, Couchiching, and then I also have some of the East Central. So I have Pine, Kanabec, Mille Lacs, and Chisago, and Isanti. Can't forget them as well. So we're going to talk today about what is public health, kind of give you a general overview. Some of you are more well-versed. I know that Frank and Dave are more well-versed in what is public health, but this will be a little bit of an overview for that. History of public health in Minnesota, Minnesota's public health system, local public health in Minnesota, and your community health board. So amongst the 3 of us, we're going to divvy out our presentation. Oh, is Dee got our slides?
Yep.
Dee, I'm going to let you move forward as you hear us talk instead of mentioning to switch, if that's okay. Okay. So there are a few standard definitions of public health. Here's one of them from the Institute of Medicine. Public health is what we as a society do collectively to assure the conditions in which people can be healthy. And then the World Health Organization describes public health as all organized measures, whether public or private, to prevent disease, promote health, and prolong life among the population as a whole. We have the 3 Ps: prevent, promote, and protect. And Joni, who was the public health supervisor here previously, always used to add a 4th P, which I always really appreciate about Cook County: partnership. And I see a lot of that happening here. So I always like to mention that, especially when I'm up here where people are familiar with Joni. Some of the public health achievements that we've had in the 20th century, I just thought it would be good to highlight some of the major steps that we've taken, accomplishments that we've had in public health. Vaccinations to reduce epidemic diseases, and we saw how important this was during COVID. Eradication of smallpox, measles. You know, we had become a country that didn't have a lot of measles, and now unfortunately we're seeing what some of the shifts in public health are doing with that. So some of these pieces about vaccination and eradication of smallpox are certainly big accomplishments that we had enjoyed. Improved motor vehicle safety, safe workplaces, control of infectious diseases, decline in death from cardiovascular disease, improvements in maternal and child health, family planning, fluoridation of drinking water, and reduction in the prevalence of tobacco use. Minnesota has a long history of commitment to the public's health. In 1872, the first state and local boards of health were established to recognize the role of government to protect the health of the community. Public health was directed at the time mainly of control of communicable diseases and public nuisances. In 1904, the first public health services began and were financed by the Red Cross and Christmas seals, mainly directed at things like school nursing, communicable diseases, and infant welfare. Family members took care of the sick at home and were taught how to provide the needed care. Soon after, in the 50s, state boards of health was firmly established, and it encouraged all communities to create local boards of health. That was so successful that soon there were 2,100 local health boards. So you can imagine having so many health boards made it difficult to coordinate and communicate. So in 1977, this state board of health was replaced by the Minnesota Department of Health.
I hadn't seen that map graphic before.
You hadn't seen that map before? Yeah. So the state and local system was created by a landmark bill that was passed in 1976, the Community Health Services Act, or you might hear it referred to as the CHS Act. The 1976 CHS Act was designed to overcome the confusion over roles and authorities and to establish a comprehensive system and an effective public health partnership among state and local governments. While the law was passed, there were over 2,100 local boards of health with which the State Board of Health was expected to communicate and coordinate. So the Local Public Health Act in 1987 established statutory responsibility with community health boards in order to clarify the accountability and roles and responsibilities. This act says that community health boards must address and implement essential local public health activities. These are defined as public health activities that each resident in Minnesota should be able to expect from their local public health department. It established public health priorities and develop a plan based on community health assessment. This must be done at least every 5 years. And that assessment must seek the public input in planning and prioritization process and should document the progress over time. So in Minnesota, the governmental public health system is a partnership. This partnership is essential to make sure everyone in Minnesota can be healthy, regardless of their age, race, or where they live. Local and tribal public health have deep community knowledge and relationships. We know that systems impact people, and a strong public health system can have an enormous impact on Minnesotans. Partnering with local and tribal public health in this way is critical, and part of why we're here today. This slide is an overview of all of the parts of the public health system. I'll speak specifically to community health boards. You'll have other opportunities to hear more about our relationship with tribes. And I'd like to spend some time reviewing what we refer to as governance and authority, or organization of structure of local public health, which Dee will address a little bit more, a little bit further in this slide or in this presentation as well. It can be a little bit confusing, but a little quick overview here is that the governance structure is held with the Community Health Board. It's who governs the activities, who can vote on the different types of activities that are performed within the governance structure. Your organizational structure is based on local control, a local decision, and that you have a Health and Human Services Board. And Dee is going to describe that a little bit more in a little bit more detail. But you can see the map that she just had up on the far right. You can see that these are the community health boards now. So in comparison to that one that had all the little tiny checkerboards, it's a little bit more streamlined, and these are where the community health boards are now. So you, in the Arrowhead, have the largest geographic area, which should be no surprise. You really have the largest geographic counties. But you've enjoyed a very robust and strong relationship with MDH and with your community health board for many years. All right. So Minnesota has strong ties between state and local agencies. We refer to our way of organizing as a partnership. Public health needs are met through state and local staff working together. The local role is primarily one of identifying public health needs and assuring that there are programs to address those needs. The state provides technical assistance, administers federal and state public health funds, and sometimes serves in a regulatory role. The public health practice section is where my job lies at the Minnesota Department of Health, and where Dee is as well. Our office exists to help ensure a strong state and local public health system in Minnesota. So leadership across Minnesota Department of Health, the local Public Health Association, and the State Community Health Services Advisory Committee, or sometimes you hear that referred to as SHAC, are working toward this vision together in transforming our public health system. We know that there are gaps in the system, and some places in Minnesota are not able to perform basic public health functions and infrastructure activities to meet the needs of counties they serve. The vision at MDH is for health equity in Minnesota, where all communities are thriving and all people have what they need to be healthy. And we can't do this without our partnership. Here's just a quick slide that shows where we are. And the Commissioner of Health is at the top there. Dr. Brooke Cunningham is our current Commissioner of Health. And she has a Deputy Commissioner, Wendy Underwood. And under each of those areas where the colors are, there are assistant commissioners that cover different bureaus. And in the pink on the far right is the Health Operations Bureau, which is where we sit, in the Public Health Strategy and Infrastructure Division. And that's where Dee and I are located. I know it's really small print. I just wanted to give you an idea of where it was that we were located in that organizational structure.
I bet you this chart is online.
Yes, you can find more detail online, yeah, right down to where my name is. In Northeast Minnesota, I just wanted to point out we have several of us regional consultants that provide the support and technical assistance that I'd mentioned from the Minnesota Department of Health. We have a public health preparedness consultant, Kayla Scrivener. She works on emergency preparedness and response with each of the counties. We have disease prevention and control field epidemiologist, Ellen Hill. We have a family home visiting and maternal child health consultant, Christy Sundquist. The Women, Infant, and Children's Program Consultant in the Northeast region is May Ye. The State Health Improvement Partnerships is Anna Johnson. Food Pools and Lodging is Jason Salom. And the Health Equity Network Coordinator is Colleen McKinney. Many of us live in different places, but we are all housed out of the Duluth District office. I live on the south end of Mille Lacs Lake. As you heard, I have Mille Lacs County as one of my counties, so I live in the region I serve, but I enjoy traveling to this area, not as frequently as I used to before COVID, but I'm really enjoying getting out and about on days like today, yes, even when it's really cold. I enjoy being up here and the beautiful drive I get to make up here. All right, so we talked a little bit about our mission at MDH, about where you live, who you are, should not determine the level of public health protection that you have. So this framework is relatively new, and we're all adapting to this a little bit different and integrating this into our public health system in Minnesota. This framework outlines the foundational responsibilities of the governmental public health system. It defines what needs to be in place everywhere for Minnesota's public health system to work anywhere, as we work toward a more seamless, responsive, and publicly supported public health system. This is a national framework that we have adopted in Minnesota, and it acknowledges that in addition to statewide foundation, health departments will provide additional services and may require more capacity in different areas to best serve their communities. When I talked about local control and local choice, it's really important that at the local level you have the ability, you know your communities best, and that you have some flexibility and ability to determine which programs best meet those needs. So you can see here there's these blue squares on the bottom are the foundational capabilities. If you think about building a house or putting down a new road, you're not going to just start putting the walls up, or you're not just going to start laying asphalt down on an unprepared road, right? There's always a foundation. You have to build up that strength in the structure. And whatever that structure might look a little bit different. Some people might have a stick-built foundation. Some might have poured concrete. But all of the components are really important that you have that firm foundation. And so we work in partnership together. And transforming the system means making sure that these components are in place. And then there are some foundational areas. Different buckets of work. You see those bubbles right above the squares. And those are kind of different buckets of work, and those areas focus more on what kinds of systems are in place within our communities to assure that these activities are happening. And at the very top is community-specific services. And those are the things that you might do here. Grace has done a lot of work about building in housing equity and childcare services, things that really do impact health and social determinants of health. And those are really important things here, but they might not be in Carleton County. They might be important there, but they might not be as much of an issue that needs to be addressed. So that's some of the ways that you have addressed those needs here in Cook County. Also, I wanted to mention too, is wrapped around the whole system is equity. I talked several times about where you live, what you look like, where you work. Those kinds of things should not affect your ability to have access to healthy conditions and healthy choices in your life. Does anyone have questions for me right now before we're going to switch over to Dee's part of the presentation?
Commissioner Gamble.
Yeah, thank you. A question related to the consultants, that in those various areas, those individuals are a resource then for participants within the state. So if there's a question that comes up, just to help inform direction and decisions, that those consultants are available to counties.
Yes.
Yeah.
Those are individuals that I work with quite a bit.
Yeah.
And program staff within the public health team. But, you know, not everyone is familiar with Ellen Hill's name, but she was definitely a phone a friend during COVID and got frequent calls from me when there was a situation that I wasn't quite sure how to address. And that's really, I think, how I use them. If something comes up that is a little bit out of the ordinary, or we're not quite sure how to address it locally, these are the people that I call. Likewise, for food pool lodging, that work is regulatory and contracted to our regional MDH office. So if somebody calls in and says, I stayed at this motel and I had a concern about rodents or water quality, whatever it might be, that's the person that I'm addressing those calls to. So these are folks that I work with very closely on a regular basis.
This is and they're regional, not statewide. These ones are just for
Regional.
Yeah, those people I mentioned are just in this region, and my position is kind of as a generalist. So sometimes things come up and we're like, oh, it doesn't really quite fit into one of those categories. And so I'll help work across MDH to find who that resource would be to provide
I
assistance.
could also provide a concrete example. So you all have heard about the resource directory website. Part of that idea was something that Janelle helped me develop. So we had an issue that we had identified in collaboration with the hospital, the clinic, and Janelle told me about a model that Pine County had used and connected me to the person in a similar position to my own in Pine County to learn more about what their process had been. So Janelle, you kind of get the widest variety of questions, I would say, but you also really help me navigate the state system because I'm not as familiar as she is with all of the nuance and resource available to us at the state level.
Yeah. I think, I don't think I know that it's beneficial to understand that in the context of words that we tend to use as umbrellas over services we provide, this concept of partnership. And we need to see the substance where that actually is played out. And that is huge given the diversity that exists within different communities. And so seeing that resource is available is an assurance, and it also underscores here's the practical application of what partnership means. So I appreciate that.
Yeah, that's the best part of my job is that partnership. And I meet monthly with I have check-in calls monthly with all of my counties, and I can be more frequent than that if they need, but that's my way of staying connected and building relationships so that when a crisis does come or when there is a need to work together on something, then we have that relationship and we can work through whatever the need or the technical assistance is, and that they feel comfortable calling me.
Yeah.
When that
As
time comes.
as a follow-up, Mr. Chair, a question I would ask, to the extent that in our partnership it is coming alongside and working together, that is an informational and a supportive approach as opposed to a mandated. And when we have mandates, that creates a sense of angst and compliance that sometimes squeezes out the sense of feeling that we're coming alongside. It's more a regulatory position than it is a supportive position. Not that regulation isn't important, but how that works itself out is huge in how we cultivate relationships where we feel that we're coming alongside and supporting each other, as opposed to a regulatory agency that creates a sense of angst for compliance and sometimes squeezes out what our objective is when it comes to the human element and how we best address that need.
Yeah, absolutely. And that's really important to us. We're one of the only agencies that has the type of partnership. The State Community Health Services Advisory Committee has a representative from each community health board, and they meet regularly and form work groups to help inform the Commissioner of Health about what priorities are across Minnesota. So that partnership is, really vital to the work that we do too. So that the areas of things that are mandated in public health are flexible to what your needs are. So, I appreciate the partnership as well.
Yeah, thank you.
And just on the note of the mandates too, I think there has been a history of that, and all counties and commissioners feel that and are aware of it. And just with the recent creation of DCYF, there's been a significant effort from the state to collaborate more with counties rather than just put upon. And I think that's spreading throughout the different state departments as well. SHAC is a really powerful example, I think, of that direction. But I know there's a lot of frustrations within SHAC too about the state says this or whatever, but there's great efforts going on there, I'd say.
I think it's a great segue, if there's no more questions at this point, for Dee's portion. She's going to start talking about state responsibilities. All right, Dee.
I wonder, Susan, I don't know if you were going to cover this, but this is going a little off script, but I wonder if it might be good to cover this slide quickly, just because we're talking about the partnership. So does that seem okay?
Sure, I can jump in on that.
It feels like, well, that's all right. We'll get to it. I'll go back.
Sorry if you couldn't hear Susan. She said that's fine. She'll jump in on that.
We can leave it. It makes sense at the end too. So we're fine. I'm fine.
You're fine? Okay.
So I'm Dee Finley, and I work in the same division as Janelle, as we talked about. I've been with the Minnesota Department of Health for 31 years. My role is to work with, I've had a variety of roles. I actually staffed the state CHS advisory committee for about 10 years. And now what I do for the last several years, 15 or so, is I work with community health boards and their leadership on the governance structures, their finance, their implementation of 145A, the local public health statute. So I kind of serve as a liaison between community health board leadership and the Minnesota Department of Health when it comes to kind of some of these higher governance level issues. And then I also help internally manage the grants that come out to community health boards, as much as one is able to herd that group of cats that are grant management. So I work a lot with Susan, I work with Grace too, but what I want to talk about is sort of that next level of the relationship between the state and local public health. As you mentioned, it is a bit of a different relationship. There is a statute that the Minnesota Department of Health is the state's official health agency, and it's responsible for developing and maintaining and organized systems of programs and services to protect and maintain the health of the people of Minnesota. Much of the structures, roles, responsibilities, and relationships are outlined in state statute, but we kind of have a flexibility with this partnership and how we make that work and how we work together. So this is the statute that sort of governs our work at the Minnesota Department of Health. It's very large. It's got immunization, infectious disease, how we deal with tuberculosis, how we deal with foodborne illnesses, our role in providing essential public health services as we did during COVID, those kind of things. This is the state role. And then the Local Public Health Act, or 145A, outlines the local responsibilities. And as Janelle mentioned, that change was through the 1976 Community Health Services Act, now called the Local Public Health Act. And it allowed boards of health, those 2,100 boards of health, to join together and work as community health boards to serve a larger population and geographic area. The Local Public Health Act outlines the shared public health responsibilities of state and local government. Becoming a community health board it sets out the requirements of a community health board, and the community health board has the general responsibility for the development and maintenance of a system of community health services under local administration within a system of state guidelines. And many of those guidelines and standards are established through work of the state CHS advisory, as you've mentioned. And what this structure allows for is community involvement in local public health, local control, an integrated statewide system. Originally, it was designed to have an adequate population base for economies of scale. That's where there is a minimum requirement of 30,000 people or 3 contiguous counties. Sometimes in some of our funding, there's a multi-county incentive that gives a little bit of an incentive for working with other counties for work. And I think in your packet, there's a link to the Local Public Health Act that outlines, it's kind of a reader's condensed version of the entire act. And within that act, at this point, there are 6 areas. There's a variety of requirements, one of which is to have a community health services administrator, to have a medical consultant. There's a variety of what has to be done, the musts that we call them. But one of those is they have to address the 6 areas of public health responsibility. And those are ensuring an adequate local public health infrastructure, promoting healthy communities, healthy behaviors, preventing the spread of infectious disease, protecting against environmental health hazards, preparing for and responding to disasters, and then assuring the quality and accessibility of health services. And these 6 areas of responsibility kind of explain what we do, but not necessarily how they're done. And as Janelle mentioned in the foundational areas in this area, this is sort of what we're shifting to, but you'll see a lot of overlap between the areas of public health responsibility and the foundational capabilities and foundational areas. And a lot of times, too, to be clear, addressing these 6 areas of responsibility doesn't necessarily mean that public health does them. They have to work with their community to figure out how they're best done for your community. What I'm going to get into now is a little bit more about the governance of public health in Minnesota. And as Janelle mentioned, this can be a little bit confusing, but once it works for us. To be a community health board, they're made up differently across the state. Some are one county or city, others are multi-county, some are human services board. In statute, there's only 3 ways to be a community health board. The governing body of a county assumes or a city council assumes that responsibility or appoints a board. The county joins a joint powers with other counties, or the county board assigns the responsibility to a human services board that is formed under a different statute. So as you can see on this, you're a part of a joint powers board, and that's what we call the governance, kind of the authority to implement public health in Minnesota. Right now, there are 53 community health boards. We just added one in the beginning of January 1st of this year. 25 of those are single county or city county community health boards. We have 4 cities that are community health boards: Minneapolis, Bloomington, Edina, and Richfield. They were grandfathered in. We have 17 multi-county community health boards and 11 human service boards. And then here's where it gets a little bit more complex. Practically, the work is done in a variety of days within this governance or community health board structure. And we refer to this as the organizational structure. Local public health is organized differently across the state. Within these community health boards, public health activities are carried out by different entities such as standalone public health departments, health and human services, and even hospitals. Public health must work with their community health boards to get buy-in and approval for many activities. The takeaway is that Minnesota's public health system involves many layers and governing bodies, each with their own authority, roles, and responsibilities. It can be a little confusing to understand community health departments, local public health departments, multi-county community health board, and who does what, but you have a lot of strong leadership there in Cook County and at the Community Health Board. So you can, it's not really an issue up in your area. There's a good relationship and a good structure for how it works. I do have some numbers in here. You know, Cook County itself would be one of the single county health and human services agencies within a joint powers board. The hospitals are all in the northwest part of the state, and that is where the county government contracts with the hospital to provide public health services. A lot of this came from times when there was a lot of home care activities taking place, and those were out of the hospital. We do have a few multi-county public health agencies, and then those are, you know, a couple of counties that have joined together within a broader community health board. So these organizational structures, it's just a different way to look at what was already on that map. And with that, and that is what I have. So that's a lot. If you have any questions, I'm happy to take them real quick.
Any questions for Dee? It doesn't look like it. Thank you.
Good. Yep.
Thanks, Dee. Can you hear me now? I'll take that as a yes.
No, she can't.
Okay. Can you hear me?
Yes.
We can hear you.
Okay. All right. Well, so I would like to just take a moment and bring it down to the local level. So we have all that at the state level, and what does that look like, boots on the ground here in Cook County? So this is our org chart for the Joint Powers Agreement for the 4 counties CHB. And you'll see at the very top is our Joint Powers Agreement between the 4 counties. We have 9 board members. 3 are from St. Louis County, and we have 2 each from Carleton, Cook, and Lake counties, and that includes at least 1 commissioner from each county, and then it could be a citizen representative as well. For Cook County, we have Commissioner Mills and Frank Seo as your representatives on the Community Health Board. And then I'm responsible to the board. And I work hand in glove with Grace and the other public health leaders in the 4 counties. While it's my job to take things to the board, I do very little without being in full agreement with the public health leaders in the 4 counties, so that we are truly working as a partnership in collaboration with each other, and looking at the work as how we can support each other as a region in addition to county-specific work. From there, the quad county leaders, those 4 county public health leaders, have their public health staff and then their public health community advisory committee that they work with to bring information, to gather information. What are the needs at the local level? What do we need to do at the board level to impact the work for the county and the region? And then I work closely with 30-plus contracted agencies across the region, the CHB staff, and our medical consultant. Dr. Kufal is from Aspirus St. Luke's, and is, again, we're statutorily required to have a medical consultant. But he's my phone a friend when things come up, and he's attendance in every one of our board meetings as well. I think that's it. Okay. So we'll jump to the next one.
Before we do,
Yeah.
I just wanted to talk about that Quad County Public Health leadership. I just think there's a lot of strength there because anytime anything comes up from one particular county, it's almost always brought to the Quad County group to discuss and work through. And then oftentimes, and that'll come to the CHB board. And just knowing that we have our professionals and staff collaborating and working on that makes our job a lot easier. And in the not too distant past, just I think after or before, just before I got on the community health board, there was quite a bit of tension between counties and working together, and that has not been the case at all.
I don't think I can stress that, the importance of that partnership and how we work together. Especially with staffing the way it is and the needs of our communities, and we're seeing more and more of a need to not look at those county lines, but to look at how do we take care of the people of our communities. And whether it's a WIC family that lives on that border between St. Louis County and Lake County, they go to the ones where they can get to the easiest. And it might not be the same county, and that's okay, because we can make that work. Maternal child health evidence-based home visiting is another area where we can cross county lines really efficiently to take care of families and not worry about that. And those partnerships and that trust amongst the leaders is vital to making sure that we do that smoothly and effectively.
I'll add a few more concrete examples. So as the smallest county in the CHP, it's also helpful to be able to, I have a relationship with the public health supervisor in Lake County, and we, can connect one-on-one or in the context of the CHB leaders meetings. And so if we're both struggling with something or wanting to brainstorm how we're providing a service, we can do that in the context of the CHB meetings or through those relationships. Additionally, when we have staff turnover, we can work as a region to make sure that there are not gaps in services. So many of our nursing functions are contracted to Sawtooth Mountain Clinic. So that renewal of purchase of service agreement that was in the consent agenda, that's what that is for. And when we had our public health nurse position turnover, we were able to work within the CHB to make sure that as the new person was training in, if there were needs for services, that we were able to reach out to a public health nurse in St. Louis County, for example, if there's a family that wants to continue participating in a service while our new staff is training in. So it's tremendously helpful to ensuring that we minimize gaps in services for community members, to work creatively with our counterparts in the region. And that's something that the CHB really allows us to do. So it's a huge asset locally.
When we look at those foundational capabilities and areas, the boxes, and then those 6 musts in Statute 145A, those should be expected in every county, no matter where you go. Ramsey County, Cook County, St. Louis County, if you need help, those are supposed to be there. They're going to look very different in every county because it's locally led. And so how we make that happen in our 4-county region, the geography and how St. Louis County can do it is very different than Lake County, but we have a lot of back and forth and with information and resources and just that support, and it's so important to make sure everyone in the area has access. And when we have funding come into the CHB, it's one chunk of money that needs to be divided up amongst 4 counties. And sometimes one of the counties takes one for the team so that everyone has that base funding to get the person in the place to do the job. Our statewide health improvement partnership is a good example of that. We didn't go straight population, we didn't go straight geography, we looked at what was the job that needed to get done for each county, and then we said that takes about this many hours a week. So how much does that cost? So everybody got that amount. And yeah, St. Louis County did not get all the money they thought that they might have otherwise. But it's how we knew it was going to work for the region and for each county to be successful.
Commissioner Gamble has a
So,
question
long way.
or comment.
Yeah, I appreciate the fact that it's not a cookie-cutter approach.
Yeah.
So often we see, when you look at the levels of governance, that decisions get made in the context of the authority and not necessarily with an understanding, appreciation, and empathy of the area that is impacted by our decisions. So the fact that there is a recognition and this partnership that allows us to define at the local level need and not just putting a cookie-cutter approach on the overall umbrella of public health is a huge attribute. A question I had was, when it comes to the medical consultant, what is the criteria that is used in making that determination? Is it someone that is available, that has the label, so that we meet the qualification? Or is there criteria that is used in determining who do we want to put in that position as a consultant?
Well, they do need to be a physician, and I might phone a friend on that one. Do you have a thought, Janelle? Okay.
By statute,
Need
they
to
have to be a
address that, or-
physician. This
Dee
was-
is asking if she should address that, or?
Yeah.
Yeah, that's fine, Dee,
Yeah.
please.
In statute right now, it is a physician licensed to practice medicine in Minnesota. And the role is to sort of serve as a medical director, but also as a link with the medical community and the community health board. There is some talk of expanding that to a provider licensed to practice medicine in Minnesota, because some people are struggling a little bit more with finding a physician. But right now, that is the statute. And Susan, say more if you want for specific to you.
I was going to say that we are lucky to have it was not easy, it's not easy to find someone willing. So that's certainly a significant factor.
Yeah, which
but-
is why there's some work being done
Yeah.
at the state level to get maybe a
broader.
nurse practitioner or a physician's assistant, or someone with that level of certification to be able to serve in the role.
Yeah, I think it's present-day culture. We find that a lot of times finding people to fill roles is challenging, so we're happy to have somebody that's willing to step up and do it. But ultimately, it's what the position is supposed to provide, and that's why criteria that identifies specifics brings more credibility to that representation other than just the title. And I mean, we have many examples of people that sit in a position with title, and we have people that, wow, this individual really is a contributor. They have lots of experience, they have knowledge, they have good personal skills and communicative skills, and so we learn through experience. Just as the reference in the previous, there was some tension in how things operated in a different area. You say, well, why is that? What created that tension? And when you see something resolved and how more effective you become when that is eliminated, a lot of those things are based upon things that you identify that becomes a criteria that is used in evaluating moving forward who sits and how we operate, because we found this works better. But I was just curious, given the significance of the consultation that we rely on in that particular area.
And it sounds like Commissioner Mills was around when Dr. Kufal was brought on board. Yeah.
Yeah.
Yeah, and we kind of talked about, like, well, who is this doctor?
Yeah.
And it happened to be Dave Lee's doctor, who was the Carlton County Director.
Right.
Oh, great. So he was like, well, it's my personal doctor, so I vouch for him.
Yeah. Yeah.
That's kind of funny, but they were struggling just to find somebody.
Sure.
So we feel really lucky, and he's a great fit, always contributes a lot and has, anecdotal experience with what's happening in where he works, and just, getting the experience from what's happening in St. Louis County, it's just, it really adds to it. And he's always open to topics and open to suggestions for topics.
And he does work with CHB staff on some things, or collaborates with Laura Bennett on things at times, so, and the maternal child health work.
Thank you.
So he's also available to us beyond his required meetings. Yeah, so let's, any other questions on?
I had one, if we do have some retired physicians in the community, if they had a license still, would they be possible candidates for something like that?
I believe so.
Consultation?
If they have an active license. So we are a bit unusual in the Northeast that the Community Health Board it's a standalone office. We are not embedded, we don't have office space in a community, in any of the 4 community, public health buildings. We're officed out of Duluth, and we do have quite a few staff. And while they are staff of the CHB, officially, they work on behalf and for all 4 counties. So this is just our one-pager of who we are at the CHB. And I'll just do a quick rundown for you to give you the lay of the land, but I'm the director. And then Stacy Stuber is our finance and information specialist. She works very closely with Plowman. And we work, all of our funding that comes to us is on a reimbursement basis. So you submit the invoice, we compile them with all 4 county invoices, we review them, and then they go off to the state typically for reimbursement, and then it gets distributed back. So that's why there's, things don't show up right away, because we do have a few-week lag in there. She's been with the CHB for a long time. Her daughter wasn't born when she started, and she's in high school, or a senior now, so that many years. She knows where all the bodies are buried. And so she's a huge asset to the CHB. And then Stacy Blair-Nelson is part-time admin support and just kind of keeps the wheels on the bus. Laura Bennett is our regional alcohol, tobacco, and other drugs regional coordinator. That is actually some funding that comes to us from the Department of Human Services. So once upon a time, again, Laura's been here for a very long time as well, the board was very creative and took the first step to say, yeah, we can take on that contract because no one else, we need it in our region and no one else could do it. And that Laura was the first employee of the board besides the director. And so she's been with us for a very long time as well. Sporthy is our regional child and family well-being program manager. So she deals all things maternal, child, and family health, including our evidence-based home visiting model, which is the Maternal Early Childhood Sustained Home Visiting, or MESH. And you have the MESH program here in Cook County with a new staff that is in the process of getting all the appropriate training to carry out that home visiting model here in here in Cook County. Taylor Blakeman is our regional coordinator for the Statewide Health Improvement Partnership, or the SHIP. And she works very closely with your local staff here. And we'll talk a little bit about what the SHIP work looks like on the ground here. But she's the kind of the media, she's the Janelle for SHIP. She works between MDH and local SHIP staff doing work on the ground to make sure all the T's gets crossed and the I's are dotted and the invoices get submitted and the work plans get submitted so that the local staff can just do as much feet on the ground work as possible. Stephanie Medina is our program manager and planner for our infrastructure work. So going back to those boxes, all of those foundational pieces and capabilities and areas, we received some funding to support and build that work here in the Northeast, in the four counties. So she is leading that work, and she supervises Jenna Olson and Mary Parsatoon. Jenna is our public health communications coordinator. She lives here in Grand Marais. So she's here in your community. She does phenomenal work putting all sorts of really great communication pieces together. The Speaking of Cannabis promotion that you might be seeing now, the posters up in stores, she designed and rolled that all out, and is sharing that statewide. That's gotten quite a few requests. She might actually be tired of talking about it because she's been presenting so many places across the state with that work. And then Mary Parsatoon is our public health planner. I believe she's been up here helping with the community health assessment and the community health improvement plan. She's just doing phenomenal work in a planning capacity, and again, working across all four counties. So all of these staff, while they're housed, in a variety of places across the four counties, and employees of the CHB, they do work on behalf of all four counties. So we're really excited to have that opportunity, and again, to have that look about how do we cross-pollinate? How do we make sure whatever we build in Carleton County can be replicated or modified to work for Cook County? And it's been really really fun to watch. And so I see my job as to just make sure the funding is there so we can keep doing it. So those are the CHB staff, and I think we wanted to talk just a moment about what this looks like feet on the ground. Dee, did you want to start with this one?
I can.
Okay.
I think this just gives some examples of how this kind of plays out. For example, because it's a shared responsibility, one example that I can address is the public health lab. We have a nationally recognized lab. If you're a member of SHAC, you might have been given the opportunity to tour the lab. And they work on environmental, maternal child health, infectious disease surveillance. Kind of a example of the partnership is that one of the activities is that our lab screens newborns at birth to see if they're at risk for any rare or hidden disorders. And then local health departments follow up with those families if they have a condition that needs some follow-up, and they might follow those families or reach out to them to see if they need any follow-up or care and make sure that they are receiving the services that they need. Another one that I'll take on, and then you can do SHIP, is the food pools and lodging it's a shared responsibility where the state health department employs staff to inspect restaurants. But in some cases, we actually delegate that, the Commissioner of Health can delegate that authority to community health boards. And then those community health boards actually do those inspections. I'm assuming that's the case with St. Louis County. I actually don't know what your food pools and lodging structure is up there. But,
Here in Cook County,
so
it's
again,
delegated.
That's kind of a shared responsibility. Go ahead.
I was just saying, here in Cook County, it's delegated, so we don't have staff at the county level or the CHB level providing that service. It's all through MDH out of the regional office in Duluth.
And then I'm gonna, Susan, do you want to, Shack, we've talked about. It's definitely a way to play out the partnership where each community health board has a representative. Often do their work through work groups to establish priorities, establish guidelines, establish statewide measures. It's a way for us to say, we've done this in partnership with local public health. And then Susan, I'll give it back to you.
Okay. And then SHIP is, the Statewide Health Improvement Partnership is statewide. It is in every county across the state. It's $17.5 million that works per year, to support community-driven solutions to expand opportunities for active living, healthy eating, and commercial-free tobacco living. MDH provides technical assistance, guidance, standards, for the best practices for this program. And then again, we have the regional coordinator in Taylor to support your local staff doing this. In Cook County, this looks like, one of the projects is the Safe Routes to School program for this current year. There's a Safe Routes to School committee that meets virtually every other month, and they're looking to assess current barriers to safe student travel and update the current Safe Routes to School plan with an outcome of at least one specific improvement initiative, such as improving signage or updating arrival or dismissal procedures. So just looking at how do we make it safer for kids in your community to walk to school. Also looking at food access. So they want to grow membership in the Food Access Council and conduct outreach with sectors that don't have representation on the Food Access Council to increase diverse representation, and then look at the policies, systems, and environmental changes that will be needed to improve access to food in the community. And I don't know, is there any other SHIP work that you would like to highlight?
No, I would say we're focused on healthy eating, active living with, we have 2 groups active in that area, and Christina Matson is coordinating those. So Food Access Council is one of them. And then the Active Living Steering Committee, which includes all the Safe Routes work. So that's the local face of SHIP here in Cook County.
And then funding for the Community Health Board comes primarily from the state, and some of that is, those are federal funds that comes to us through the state. And then we do also grant writing for other opportunities that come our way when they're appropriate. Sometimes we look at small foundation partnerships for those unrestricted funds for some things like, we don't use state and federal funds to buy food and those types of things. So if you're going to do community engagement, it's nice to be a host and to offer people a cup of coffee and that type of thing. And so how do we do that? And so we get creative with fund seeking to make sure we can do those kinds of things that make it a welcoming community event, especially when we're asking people to give us feedback on things. So the CHB is the legal and governing entity for all of those funds that come through. So we're audited annually. We conduct reviews of each county. We do financial site visits annually, and I review all the audits for each county as well, so that we do the due diligence. All in all, I hope that what this Community Health Board does for the counties is keeps the money coming in and reduces the burden of reporting and those types of things, so that they can just stay focused on doing the good work. Staff feet on the ground, so the public health nurse can focus on nursing and not all of the recording. And we need things documented. We know that for transparency. But I hope that the CHB takes on a lot of that due diligence to maintain fidelity of programs, so that the county staff can just stay focused on their work.
I would add, I think the other benefit is looking back at that org chart and all the faces on there. There are pieces that the CHB has been able to build up so that we do not have to build that up locally. It wouldn't be possible for us to have a full-time communications staff specific to public health or a planner specific to public health. We don't have that much. We don't have the funding to support it. We might not have the workload to support a full-time staff person, but if the region can provide that assistance to us through a staff housed regionally, then we can access supports that we wouldn't otherwise have without having to build up our staffing locally, and that's hugely beneficial. So something I've been really grateful for working with the CHB.
Well, I hope in listening to us today, part of the flavor that you've gotten is that it's really important to us to be in these relationships, that we don't do this work in a vacuum, and that it's really important also to us that local issues are addressed locally, that you have that voice and you're able to express that opinion despite the fact that you're the smallest county in the CHB. You've done really mighty things, and Grace talked about my referencing another county that she was able to access. There are many, many, many times where I reference Grace. Here's some work, and so I'm often connecting people from across the state, and Jenna. So you have representatives right here in Grand Marais that are impacting the health of all Minnesotans. And that's, I think, to me, the crux of that partnership is across the state, not just at us at MDH or Susan at the CHB or Grace at the county. It's all of us together, so that we work together to promote health and protect individuals and prevent illness and disease. So we might do our work a little bit differently than any of the other departments you've seen. You didn't see that we have these specific mandates that you might see from other programs, that you have to do X, Y, and Z. But you do need to do some work to help the health of the community and help assure the health of the community. How you do that is a little bit different. So in public health, we're working on prevention activities, and that seems a little bit different too, right? Sometimes that can be a little bit harder to focus on. So I really appreciate you giving us the time today to talk about that. We love to talk public health, so we can talk forever. But definitely reach out if you have questions. You can reach out to any of the three of us, but like I said, I'm oftentimes the contact point, and we'll lobby you to somebody else or volley you off to somebody else if need be. Do you have any other questions for any of the three of us before we conclude?
No, thank you.
All right. Thank you.
Really appreciate the presentation and the overview and the details and the partnership.
Thank you. Yeah, thank you, Janelle and Susan and Dee, for being with us this morning. Commissioner Mills, would you like me to move into the director's report?
Yes, please.
Okay. So the first item in the director's report is our org chart, which is updated as of January 13th. You'll see that some of the staff that positions are no longer vacant joined us this morning. So on that supervisor line item, Sarah Dragswick started as the Behavioral Health Services Supervisor with us last Wednesday. And then under the Children Family Services team, there Amaris Fisher and Daniel McFarland, you'll see that those positions are now filled with them taking on those roles in case management. At this point, the position that is open and we are currently interviewing for is the public health supervisor position. So we have started to schedule interviews for later this week and are hoping to have some good news to share with you by the time this board meets in February. And that's the only position at this point that is posted and we're currently interviewing for. Some of the vacancies that you'll see on this org chart, we have paused on hiring until we receive and review the consultant's report in the near future. So more to come on those positions. Any questions on the org chart before I go into other pieces of the director's report? Well, I feel very familiar with the Public Health and Human Services Board, but this is my first time. I guess I could be on the staff introductions as well in the Public Health and Human Services Director role. So thank you all for putting your faith and trust in me as I step into this position. I'm really striving for our department to do its best work in the new year, as well as myself stepping into the director role. While I've been with the department for quite some time, there are things that I'm learning and becoming more familiar with as I step into this role. So I appreciate your patience and flexibility as I learn and grow into this new position in the new year. Notes. So notes from the public health team specifically. The pop-up food pantry continues to operate right here in the courthouse lobby with updated signage and a survey to better understand utilization. There's a media release planned for the near future to publicize the extension of this project. And the plan at this point is to present to the April PHHS board meeting regarding the pop-up pantry and evaluation of both its use and the resources needed to operate. I would consider reaching out to other members of the Food Access Council who are doing other food access work. Maybe that would be a good meeting to highlight some of those other community efforts as well, alongside a review of the pop-up pantry. The youth prevention scavenger hunt has been extended through the month of January to drive additional participation. Outreach in both local middle schools for prevention activities has been very successful, with lots of conversation and links to local resources being provided by our youth prevention specialist, Rocio Rivas. Both Rana and Frank will be familiar with our last advisory council meetings of an effort to expand recruitment for both our PHHS advisory council and the local mental health advisory council in the coming months. And to tie back in with the community health board presentation, we received support from one of our community health board staff, the communications specialist, Jenna Olson, in coming up with a campaign for child and teen checkups. And you'll see that campaign debuting in Northern Wilds starting this month. So Jen, this is a great example of how we use support from the Community Health Board to further both local public health and public health across the region. So we recruited families, very short notice. I was one of the families who participated, along with Daniel, who you met this morning, and Andrea Tofty, to take photos and get quotes from local families with young children about the importance of bringing your children to their regular checkups, their annual checkups. And so there are quotes and photos from local families that Jenna helped put together that will be debuting in Northern Wilds this month. And those images and quotes will also be available for use by other counties in the region as well. So that's an example of how we share resources and expertise to further the goal of public health. Some of them have also gone out on PHHS social media.
That is true. I should note that they also went out on social media. So they're going, it's a what is it, multi-channel communications campaign. Another note, so regarding state and federal funding, there is a lot that you may have seen in the news about funding for human services programs specifically, and public health as well. So I will give as much of an update as I can at this point. So
On February 9th, USDA sent Minnesota a letter that it would be freezing funds to the state. This decision was temporarily blocked in federal court last week. The state agencies that administer these funds within Minnesota, that's DCYF for SNAP and MDH for WIC, provide counties with updates on the situation. At this point, there is no impact to services. We will continue to monitor the situation and inform both the board and the public as the situation evolves. In addition, on January 6th, Federal Health and Human Services indicated that it would freeze federal child care assistance and other social service programs in Minnesota. This decision was temporarily blocked in federal court on January 9th. The services that would have been impacted by this freeze include the Child Care Assistance Program and the Minnesota Family Investment Program, along with the Social Services Block Grant. All continue to operate as usual at this time. Again, we will continue to monitor the situation and inform both the board and the public as the situation evolves.
Grace, you said February 9th?
Oh, I meant January.
Okay.
I apologize. Yeah, all of these are January
Yep,
dates.
yep.
So they're all updates within the first 3 weeks of 2026.
Thank you.
So AMC, MAXA, the local Public Health Association, these are all state-level groups that provide updates to county leadership when situations like this could impact the services that we provide to residents. So as I said, at this point, it's a monitor and inform as the situation evolves. And that really concludes my director's report at this time. Happy to take questions.
None here. It doesn't look like. Frank, do you have anything? Oh, Gary? No.
Yeah, thank you, Mr. Chair. I would just
No, good, thanks.
make a statement, Grace, that in your position, coming through the organization and your lengthy service to the community, that the foundational things that we see in you that you bring to the position, that we want to encourage you. And it's a situation where we celebrate the fact that you are in the position because you bring so much to the position, and we've had the opportunity to observe and to know what you're capable of. So the best thing we can do for you is understand the environment in which we've asked you to take leadership and to support you and encourage you. So thank you.
Well, I appreciate that. Thank you, Commissioner Beck-Gamble.
All right. Well, thank you, Grace, and we'll move on for items for board action, which is empty right now. And that moves us on to our committee reports. Probably not a whole lot going on since the first of the year, but we'll go down the list here. Active Living Steering Committee, Commissioner White.
I have
Thank you.
nothing to report on that, nor on the AEOA. We've not met yet. The Arrowhead Health Alliance has not met. But there was, and nothing new to report from the Council on Aging.
Okay, boom, thank you. Commissioner Gamble, how about ARC there?
Yeah, thank you, Mr. Chair. We met January 16th. It was our regular board meeting monthly for January, the new year. We also, that meeting was followed by a joint meeting with the advisory committee, and former longtime Cook County probation officer Steve Borrud represents Cook County on this committee. Interesting in our discussion, this probation survey report for Cook County, January through December 2025, reflects a total of 76 individuals on probation. And that breaks down the result of their being on probation. 35 is a result of felony, 30 for gross misdemeanor, 11 for misdemeanor, and there was one juvenile. The Arrowhead Juvenile Center, which is a portion of the ARC, the Juvenile Center per diems for the fourth quarter 2025, they budgeted $300,000, and actual receipts came out to $538,568. If you look at the services provided by ARC in the Arrowhead Juvenile Center, counties using AJC in Wisconsin are Ashland, Bayfield, and St. Croix counties. In Minnesota, we have Blue Earth, Douglas, Faribault, Hennepin, Itasca, Nobles, and Wright. Why that's significant is saying that aside from those that are ARC in association, Carleton, St. Louis County, Lake, and Cook, we have considerable participation with these other counties throughout the state. 85% of the juveniles who come into corrections are functionally illiterate. In other words, 85% of those individuals coming can't read or write. That's significant. It's also a statement on our education. It's also worth noting that no other counties in the state of Minnesota, out of the 87 counties, have a corrections facility like NERC, the Northeast Regional Corrections Center. Other counties, when they have offenders, they send them to serve their time in jail. And that's the unique thing about ARC and NERC, is the fact that we bring them in to try to reshape and to educate many that get their GED, and we celebrate that. When you look at the testimonials, and we've got a number in the packet in this meeting of people whose lives have been reshaped as a result of being in an environment where people come alongside and genuinely care and equip them. So it's not just doing time, it is reshaping. So very, very, very fortunate that we have this partnership with NERC.
Let's see, Child Care Solutions Subcommittee, and I think that was Commissioner Storley, but now Commissioner Gamble, is that right? But
Yeah.
maybe they didn't meet.
I can add that with Nancy's transition, the group hasn't met. We do intend to have that group begin to meet in the new year, but it likely won't be until February or March at this point. So I will keep, Commissioner Gamble is a representative on the group.
Yes.
I will keep Commissioner Gamble updated as
Thank
we
you.
set a date.
Okay, thank you.
We reorganized a little bit.
Okay.
Community Health Board has not met, had a wonderful presentation, of course. Local Mental Health Advisory Council, Lorena.
Okay, I was elected, we met on the 13th of January. I was elected to be chair again, and vice chair will be Cecilia Bloomquist. And we talked about we're going to meet every other month now, because there are a lot of meetings that people have to go to, and we can get it done in that amount of time. So that's a change. We will meet starting in February and then April and June, so we can do that. And then we talked a lot about, people were worried about just the stress and anxiety that people have now with some events in our community, some in Minneapolis, and people fear things for their friends and grandchildren and whatever. So we talked about that, and maybe trying to have some programs later or something. I don't know, nothing definite was really suggested, but just an awareness of this. And maybe trying to help people at some point, with understanding what's going on, how to help yourself not be too anxious. I don't know. So that's all I have.
Thank you.
Anything else, Grace? You think I forgot? Or?
No, I will add that Rocio Rivas, our youth prevention specialist, is working on a January article on talking to kids about challenging situations with some of the resources that Erica had shared and that Rocio had shared in that meeting.
Wonderful, thanks.
I already touched on the Council on Aging. That's next is Emergency Preparedness Committee, Commissioner Sullivan.
We have not met yet.
Thank you. Healthcare Planning Committee, Commissioner Storley.
Have not met.
Okay.
I will say I did talk with Erin Watson and Sawtooth Mountain Clinic about healthcare planning, and we had discussed seeing if we could incorporate what was in healthcare planning to our PHHS Advisory Council, so that providers would be providing updates in the context of that meeting.
Nice.
So more to come on that, but it may be that group sunsets.
Oh, okay. Thank
Okay.
you. Anything from NACO, Commissioner Storley?
Next week.
Okay. And then Northeast Minnesota Office of Job Training Program, Commissioner Gamble. oh yeah, we're axing that. No, we're looking into that, yeah.
Yes, yeah, that's a good way to
The
put it.
bylaws is.
Yeah,
kind of
and my intent is to call director and have a conversation and be informed on that, so our basis, based upon assumption and the years of experience, is well-founded in making that decision.
Sounds like an excellent approach. North Shore Collaborative has not met. PHHS Advisory Council. Frank, anything you'd like to share from that? Or did they meet?
Yes, thank you. Thank you. One of the things that we did was election of officers, and I am pleased to announce that I am continuing as chairman for this 2026. But I'm even more pleased to announce that we have a vice chairman.
Yes.
Our newest member, Crystal, welcome. So, thank you very much. Grace also presented the results of an online survey that was taken of the membership with review to our mission and changes that we might need to make, and I'll be reporting on that after further discussion with Grace next time. And let's see, also weighed in on the as Grace described, the pop-up food shelf right here at the courthouse, and looking forward to getting some results from the evaluation that's coming up on that. And I'm sorry, my brain's at a bit of a fog. It was, and this was a suggestion which was passed to form a subcommittee for recruitment, and at Grace's suggestion, that would be a joint subcommittee with the local mental health advisory council, and I'm looking forward to getting together with them to establish a joint plan for recruitment for both advisory councils. Thank you.
Thank you, Frank.
Any questions?
I don't see any. Thank you very much. The next one is the Food Access Council. Hasn't met since, we have met since the last PHHS meeting, but I gave a little brief update of our past regular meeting. There's a wonderful article on WTIP's website about the super shelf model and just the goings-ons there that I'd encourage everyone to check out if you haven't already. Last thing is for the good of the order. Anything there? Thank you for your patience and help this morning, and we are adjourned.
Thank you.
Even though we started 10 minutes later, it's great.
Kristen, should I stay on for a while, or am I going to transfer to a different number?
You're on the phone, right?
Yes.
I think that'd be great. We just had